Chapter 75 Physiology of Gastrointestinal Diseases. Coming to disorders of swallowing and the esophagus, let's talk about paralysis of the swallowing mechanism. Damage to the 5th, 9th, or 10th cerebral nerve can cause paralysis of significant portions of the swallowing mechanism. Because 5th and 9th nerves, they are the afferents for the afferents for the pharyngeal stage, and also the efferents along with the 10th and 12th nerves. Okay, and the vagus itself, the 10th nerve, is both the afferent and the efferent for the esophageal stage of swallowing. So, damage to these nerves can cause paralysis of significant portions of the swallowing mechanism. In addition, a few diseases such as poliomyelitis or encephalitis can prevent normal swallowing by damaging the swallowing center in the brainstem. Paralysis of the swallowing muscles, as occurs in persons with muscle dystrophy or as a result of failure of neuromuscular transmission in persons with myasthenia gravis or botulism, can also prevent normal swallowing. When the swallowing mechanism is partially or totally paralyzed, the abnormalities that occur include complete abrogation of the swallowing act so that swallowing cannot occur, failure of the glottis to close so that food passes into the lungs instead of the esophagus, failure of the soft palate and uvula to close the posterior nares so that food refluxes into the nose during swallowing. One of the most serious instances of paralysis of the swallowing mechanism occurs when patients are in a state of deep anesthesia. While on the operation table, they sometimes vomit large quantities of materials from the stomach into the pharynx, and instead of swallowing the materials again, they simply suck them into the trachea because the anesthetic has blocked the reflex mechanism of swallowing. As a result, such patients may choke to death on their own vomitus. Coming to achalasia and megaesophagus, achalasia is a condition in which the lower esophageal sphincter fails to relax during swallowing. As a result, the food swallowed into the esophagus fails to pass from the esophagus into the stomach. Pathological studies have shown damage in the neural network of the myenteric plexus in the lower two-thirds of the esophagus. As a result, the musculature of the lower esophagus remains spastically contracted, and the myenteric plexus has lost its ability to transmit a signal to cause receptive relaxation of the gastroesophageal sphincter as food approaches the sphincter during swallowing. When achalasia becomes severe, the esophagus cannot empty the swallowed food into the stomach for many hours instead of the few seconds that is the normal time. Over months and years, the esophagus becomes tremendously enlarged until it can often hold as much as 1 liter of food, which often becomes putridly infected during the long periods of esophageal stasis. The infection may also cause ulceration of the esophageal mucosa, sometimes leading to severe substernal pain or even rupture and death. Considerable benefit can be achieved by stretching the lower end of the esophagus by means of a balloon inflated on the end of a swallowed esophageal tube. Antispasmodic drugs that relax the smooth muscles can also be helpful. Okay, so one thing you need to remember in achalasia cardia, there is substernal pain in case of infection of the food that is stored in the distal part of the esophagus. Okay. Now, coming to disorders of the stomach, let's talk about gastritis, which is an inflammation of the gastric mucosa. The inflammation of gastritis may be only superficial and therefore not very harmful, or it can penetrate deeply into the gastric mucosa in many long-standing cases, causing almost complete atrophy of the gastric mucosa. In a few cases, gastritis can be acute and severe, with ulcerative excoriation of the stomach mucosa by the stomach's own peptic secretions. Research suggests that gastritis often is caused by chronic bacterial infection of the gastric mucosa. This condition often can be treated successfully with an intensive regimen of antibacterial therapy. In addition, certain ingested irritant substances can be especially damaging to the protective gastric mucosal barrier, that is to the mucosal glands and to the tight epithelial junctions between the gastric lining cells, often leading to severe or acute chronic gastritis. Two of the most common of these substances are excesses of alcohol or aspirin. Gastric barrier and its penetration in gastritis. Absorption of the food from the stomach directly into the blood is normally slight. This low level of absorption is mainly due to specific features of the gastric mucosa. It is lined with highly resistant mucus cells that secrete viscid and adherent mucus, and it has tight junctions between the epithelial cells. These two features, the mucus cells and the epithelial tight junctions, together plus other impediments to gastric absorption, are called the gastric barrier. The gastric barrier is normally resistant enough to diffusion, so that even the highly concentrated hydrogen ions of the gastric juice, averaging about 100,000 times the concentration of H+ in the plasma, seldom diffuse even to the slightest extent through the lining mucus as far as the epithelial membrane itself. In gastritis, the permeability of the barrier is greatly increased. The hydrogen ions then diffuse into the stomach epithelium, creating additional havoc and leading to a vicious cycle of progressive stomach mucosal damage and atrophy. It also makes the mucosa susceptible to digestion by the peptic digestive enzymes, thus frequently resulting in a gastric ulcer. Chronic gastritis can lead to gastric atrophy and loss of stomach secretions. In many people who have chronic gastritis, the mucosa gradually becomes more and more atrophic until little or no gastric gland digestive secretion remains. It is also believed that in some people, autoimmunity develops against the gastric mucosa, which also leads eventually to gastric atrophy. Loss of stomach secretions in gastric atrophy leads to echlorhydria and occasionally pernicious anemia. Echlorhydria means simply that the stomach fails to secrete hydrochloric acid. It is diagnosed when the pH of gastric secretions falls to decrease below 6.5 after maximal stimulation. Hypochlorhydria means diminished acid secretion. When acid is not secreted, pepsin also is usually not secreted. Even when it is secreted, the lack of acid prevents it from functioning because pepsin requires an acid medium for activity. Gastric atrophy may cause pernicious anemia. Pernicious anemia commonly accompanies gastric atrophy and echlorhydria. Normal gastric secretions contain a glycoprotein called the Castle's intrinsic factor, secreted by same parietal cells that secrete HCl. Intrinsic factor must be present for adequate absorption of vitamin B12 from the ileum. That is, intrinsic factor combines with vitamin B12 in the stomach and protects it from being digested and destroyed as it passes to the small intestine. Then, when the intrinsic factor vitamin B12 complex reaches the terminal ileum, the intrinsic factor binds with receptors on the ileal epithelial surface, which in turn makes it possible for vitamin B12 to be absorbed. In the absence of intrinsic factor, only about 1 by 50 of the vitamin B12 is absorbed. In addition, without the intrinsic factor, an adequate amount of B12 is not made available from the foods to cause young, newly forming red blood cells to mature in the bone marrow, and the result is pernicious anemia. We have already discussed peptic ulcers in the previous chapters. Now coming to disorders of the small intestine, a serious cause of abnormal digestion is the failure of pancreas to secrete pancreatic juice into the small intestine. Lack of pancreatic secretion frequently occurs in patients with pancreatitis, or when the pancreatic duct is blocked by a gallstone at the ampulla of Vater, or after the head of the pancreas has been removed because of malignancy. Okay, so loss of pancreatic juice means loss of trypsin, chymotrypsin, carboxypeptidase, and pancreatic amylase, pancreatic lipase, and few other digestive enzymes. Without these enzymes, up to 60% of the fat entering the small intestine may not be absorbed, along with 1/3 to 1/2 of the proteins and carbohydrates. As a result, large portions of the ingested food cannot be used for nutrition and copious fatty feces are excreted. Coming to pancreatitis, it is an inflammation of the pancreas. It can occur in the form of either acute pancreatitis or chronic pancreatitis. The most common cause of pancreatitis is drinking excess alcohol, and the second most common cause is blockage of the papilla of Vater by a gallstone. The two causes together account for more than 90% of the cases. When a gallstone blocks the papilla of Vater, the main secretory duct from the pancreas and the common bile duct are blocked. The pancreatic enzymes are then dammed up in the ducts and acini of the pancreas. Eventually, so much trypsinogen accumulates that it overcomes the trypsin inhibitor in the secretions, and a small quantity of trypsinogen becomes activated to form trypsin. Once this happens, the trypsin activates still more trypsinogen as well as chymotrypsinogen and carboxypolypeptidase, resulting in a vicious cycle until most of the proteolytic enzymes in the pancreatic ducts and acini have become activated. These enzymes rapidly digest the large portions of the pancreas itself, sometimes completely and permanently destroying the ability of the pancreas to secrete digestive enzymes. And we have malabsorption by the small intestinal mucosa, which is called sprue. Occasionally, nutrients are not adequately absorbed from the small intestine even though the food has been well digested. Several diseases can cause decreased absorption by the mucosa. They are often classified together under the general term sprue, which means decreased absorption by the small intestinal mucosa. Malabsorption can also occur when large portions of the small intestine have been removed. Coming to non-tropical sprue, one type of sprue called variously idiopathic sprue or celiac disease in children or gluten enteropathy results from the toxic effects of gluten present in certain types of grains, especially wheat and rye. Only some people are susceptible to this effect, but in those who are susceptible, gluten has a direct destructive effect on intestinal enterocytes. In milder forms of the disease, only the microvilli of the absorbing enterocytes on the villi are destroyed, thus decreasing the absorptive surface area as much as twofold. In more severe forms, the villi become blunted or disappear altogether, thus still further reducing the absorptive area of the gut. Removal of wheat and rye flour from the diet frequently results in cure within weeks, especially in children with this disease. Coming to tropical sprue, a different type of sprue called tropical sprue frequently occurs in the tropics and can often be treated with antibacterial agents. Even though no specific bacterium has been implicated as the cause, it is believed that this variety of sprue is usually caused by inflammation of the intestinal mucosa resulting from unidentified infectious agents. Coming to malabsorption in sprue, in the early stages of sprue, intestinal absorption of fat is more impaired than absorption of other digestive products. The fat that appears in the stools is almost entirely in the form of salts or fatty acids rather than undigested fat, demonstrating that the problem is of absorption, not of digestion. In fact, the condition is frequently called steatorrhea, which means simply excess of fat in the stools. So, sprue is accompanied by steatorrhea. In severe cases of sprue, in addition to malabsorption of fats, impaired absorption of proteins, carbohydrates, calcium, vitamin K, folic acid, and vitamin B12 also occurs. As a result, the person experiences severe nutritional deficiency, which often results in wasting of the body, osteomalacia, inadequate blood coagulation caused by lack of vitamin K, and macrocytic anemia of the pernicious type, resulting from diminished vitamin B12 and folic acid absorption. Coming to disorders of the large intestine, we have constipation, which means slow movement of feces through the large intestine. It is often associated with large quantities of dry hard feces in the descending colon that accumulate because of excess absorption of fluid or insufficient fluid intake. Any pathology of the intestines that obstructs movement of intestinal contents, such as tumors, adhesions that constrict the intestines, or ulcers, can cause constipation. Infants are seldom constipated, but part of their training in early years of life requires that they learn to control defecation. This control is effected by inhibiting the natural defecation reflexes. Clinical experience shows that if one does not allow defecation to occur when the defecation reflexes are excited, or if one overuses laxatives to take the place of natural bowel function, the reflexes become progressively less strong over months or years and the colon becomes atonic. For this reason, if a person establishes regular bowel habits early in life, defecating when the gastrocolic and duodenocolic reflexes cause mass movements in the large intestine, development of constipation in later life is less likely. Constipation can also result from spasm of small segment of the sigmoid colon. Motility normally is weak in the large intestine, so even a degree of spasm may cause serious constipation. After the constipation has continued for several days and excess feces have accumulated above a spastic sigmoid colon, excessive colonic secretions often lead to a day or so of diarrhea. After this, the cycle begins again with repeated bouts of alternating constipation and diarrhea. Now let's talk about megacolon or Hertzsprung disease. Occasionally, constipation is so severe that bowel movements occur only once every several days or sometimes only once a week. This phenomenon allows tremendous quantities of fecal matter to accumulate in the colon, causing the colon to sometimes distend to a diameter of 3 to 4 inches. This condition is called megacolon or Hertzsprung disease. One cause of megacolon is lack of or deficiency of ganglion cells in the meandric plexus in a segment of the sigmoid colon. As a consequence, neither defecation reflexes nor strong peristaltic motility can occur in this area of the large intestine. The sigmoid becomes small and almost spastic while feces accumulate proximal to this area, causing megacolon in the ascending transverse and descending colons. Now coming to diarrhea, it results from rapid movement of fecal matter through the large intestine. Several causes of diarrhea with important physiological sequelae are the following. We have enteritis, which is an inflammation of the intestinal tract. Enteritis means inflammation usually caused by a virus or bacteria in the intestinal tract. In usual infectious diarrhea, the infection is most extensive in the large intestine and the distal end of the ileum. Everywhere the infection is present, the mucosa becomes irritated and its rate of secretion becomes greatly enhanced. In addition, motility of the intestinal wall usually increases markedly. As a result, large quantities of fluid are made available for washing the infectious agent towards the anus, and at the same time strong propulsive movements propel this fluid forward. This mechanism is important for ridding the intestinal tract of a debilitating infection. Of special interest is diarrhea caused by cholera and less often by other bacteria such as some pathogenic colon bacilli. Cholera toxin directly stimulates excessive secretion of electrolytes and fluid from the crypts of Libercune in the distal ileum and colon. The amount can be 10 to 12 liters per day, although the colon can usually reabsorb a maximum of only 6 to 8 liters per day. Therefore, loss of fluid and electrolytes can be so debilitating within several days that death can ensue. The most important physiological basis of therapy in cholera is to replace the fluid and electrolytes as rapidly as they are lost, mainly by giving the patient intravenous solutions. With proper therapy, along with the use of antibiotics, almost no persons with cholera die, but without therapy, up to 50% of patients die. Coming to psychogenic diarrhea, most people are familiar with the diarrhea that accompanies periods of nervous tension, such as during examination time or when a soldier is about to go into battle. This type of diarrhea, called psychogenic emotional diarrhea, is caused by excessive stimulation of parasympathetic nervous system, which greatly excites both the motility and excess secretion of mucus in the distal colon. These two effects added together can cause marked diarrhea. Ulcerative colitis. It is a disease in which extensive areas of the walls of the large intestine become inflamed and ulcerated. The motility of the ulcerated colon is often so great that mass movements occur much of the day rather than for the usual 10 to 30 minutes. Also, the colon's secretions are greatly enhanced. As a result, the patient has repeated diarrheal bowel movements. The cause of ulcerative colitis is unknown. Some clinicians believe that it results from an allergic or immune destructive effect, but it could also result from chronic bacterial infection not yet understood. Whatever the cause, there is a strong hereditary tendency for susceptibility to ulcerative colitis. Once the condition has progressed far, the ulcers seldom will heal until an ileostomy is performed to allow the small intestinal contents to drain into the exterior rather than to pass through the colon. Even then, ulcers sometimes fail to heal, and the only solution might be surgical removal of the entire colon. Coming to paralysis of defecation in persons with spinal cord injuries, defecation is normally initiated by accumulating feces in the rectum, which causes a spinal cord mediated defecation reflex passing from the rectum to the conus medullaris of the spinal cord and then back to the descending colon, sigmoid, rectum, and anus. When the spinal cord is injured somewhere between the conus medullaris and the brain, that is, whenever there is a lesion in the upper spinal cord, the voluntary portion of the defecation act is blocked while the basic cord reflex for defecation is still intact. Nevertheless, the loss of the voluntary aid to defecation, that is, loss of the increased abdominal pressure and relaxation of the voluntary anal sphincter, often makes defecation a difficult process in the person with this type of upper cord injury. However, because a cord defecation reflex can still occur, a small enema to excite action of this cord reflex, usually given in the morning shortly after a meal, can cause adequate defecation. In this way, people with spinal cord injuries that do not destroy the conus medullaris of the spinal cord can usually control their bowel movements each day. Coming to the general disorders of the gastrointestinal tract, we have vomiting. Vomiting is the means by which the upper GIT rids itself of contents when almost any part of the upper tract becomes excessively irritated, over-distended, or even over-excitable. Excessive distension or irritation of the duodenum provides an especially strong stimulus for vomiting. The sensory signals that initiate vomiting originate mainly from the pharynx, esophagus, stomach, and upper portions of the small intestine, that is, from the upper GI tract. The nerve impulses are transmitted by both vagal afferents and sympathetic afferents to the various nuclei that are distributed in the brainstem, especially in the area postrema, that altogether are called the vomiting center. From here, motor impulses that cause the actual vomiting are transmitted from the vomiting center by way of the 5th, 7th, 9th, 10th, and 12th cranial nerves, that is, all the efferents of the esophageal and pharyngeal stages of deglutition plus the 7th cranial nerve as well. They are transmitted through these efferents to the upper GIT, through vagal and sympathetic nerves to the lower GI tract, and through spinal nerves to the diaphragm and abdominal muscles. Coming to antiperistalsis, it is a prelude to vomiting. In the early stages of excessive gastrointestinal irritation or over-distension, antiperistalsis begins to occur often many minutes before vomiting appears. Antiperistalsis means up the digestive tract rather than downward. It may begin as far down in the intestinal tract as the ileum, and the antiperistaltic wave travels backward up the intestine at a rate of 2 to 3 centimeters per second. This process can actually push a large share of the lower small intestinal contents all the way back to the duodenum and the stomach within 3 to 5 minutes. Then, as these upper portions of the GIT, especially the duodenum, become overly distended, this distension becomes the exciting factor that initiates the actual vomiting act. At the onset of vomiting, strong intrinsic contractions occur in both the duodenum and the stomach, along with partial relaxation of the esophageal stomach sphincter, thus allowing vomitus to begin moving from the stomach into the esophagus. From here, a specific vomiting act involving the abdominal muscles takes over and expels the vomitus to the exterior, as explained in the following. Once the vomiting center has been sufficiently stimulated, that is the area postrema, and the vomiting act has been instituted, the first effects are deep breath, then raising of the hyoid bone and larynx to pull the upper esophageal sphincter open, closing of the glottis to prevent vomitus flow into the lungs, and then lifting of the soft palate and the uvula to close the posterior nares. Next comes a strong downward contraction of the diaphragm along with simultaneous contraction of all the abdominal wall muscles, which squeezes the stomach between the diaphragm and the abdominal muscles, building the intragastric pressure to a high level. Finally, the lower esophageal sphincter relaxes completely, allowing expulsion of the gastric contents upward through the esophagus. Thus, the vomiting act results from a squeezing action of the muscles of the abdomen associated with simultaneous contraction of the stomach wall and opening of the esophageal sphincters so that gastric contents can be expelled. Coming to the chemoreceptor trigger zone in the brain medulla, it is for initiation of vomiting by drugs or motion sickness. Aside from the vomiting initiated by irritative stimuli in the GIT, vomiting can also be caused by nervous signals arising in areas of the brain. This mechanism is particularly true for a small area called the chemoreceptor trigger zone for vomiting, located in the area postrema on the lateral walls of the fourth ventricle. Electrical stimulation of this area can initiate vomiting, but more importantly, administration of certain drugs, including apomorphine, morphine, and some digitalis derivatives, can directly stimulate this chemoreceptor trigger zone and initiate vomiting. Destruction of this area blocks this type of vomiting, but does not block vomiting resulting from irritative stimuli in the GIT itself. Furthermore, it is well known that rapidly changing direction or rhythm of motion of the body can cause certain people to vomit. The mechanism for this phenomenon is the following. The motion stimulates receptors in the vestibular labyrinth of the inner ear, and from here, impulses are transmitted mainly by way of the brainstem vestibular nuclei into the cerebellum, then to the chemoreceptor trigger zone, and finally to the vomiting center to cause vomiting. Okay, so here you can see obstruction in different parts of the GI tract. One point we need to know is that the sound made during vomiting, it is called retching. Now coming to nausea, the sensation of nausea is often a prodrome of vomiting. Nausea is a conscious recognition of subconscious excitation in an area of the medulla closely associated with or part of the vomiting center. It can be caused by irritative impulses coming from the GIT or impulses that originate in the lower brain associated with motion sickness or impulses from the cerebral cortex to initiate vomiting. Vomiting occurs occasionally without the prodromal sensation of nausea, which indicates that only certain portions of the vomiting center are associated with the sensation of nausea. Coming to gastrointestinal obstruction, the GIT can become obstructed at almost any point along its course as shown here. Some common causes of obstruction are cancer or fibrotic constriction resulting from ulceration or from peritoneal adhesions. Because of ulcer or adhesions, and we have spasm of a segment of the gut or because of paralysis of a segment of the gut. The abnormal consequences of obstruction depend on the point in the GIT that becomes obstructed. If the obstruction occurs at the pylorus, which often results from fibrotic constriction after peptic ulceration, persistent vomiting of stomach contents occurs. The vomiting depresses bodily nutrition. It also causes excessive loss of hydrogen ions from the stomach and can result in varying degrees of whole body metabolic alkalosis. If the obstruction is beyond the stomach, antiperistaltic reflux from the small intestine causes intestinal juices to flow backward into the stomach, and these juices are vomited along with the stomach secretions. In this instance, the person loses large amounts of water and electrolytes. He or she becomes severely dehydrated, but the loss of acid from the stomach and base from the small intestine may be approximately equal, so little change in acid-base balance occurs. If the obstruction is near the distal end of the large intestine, feces can accumulate in the colon for a week or more. The patient develops an intense feeling of constipation, but at first the vomiting is not severe. After the large intestine has become completely filled and it finally becomes impossible for additional chyme to move from the small intestine to the large intestine, severe vomiting then occurs. Prolonged obstruction of the large intestine can finally cause rupture of the intestine or dehydration and circulatory shock resulting from the severe vomiting. Finally, we have gases in the gastrointestinal tract which are called flatus. They can enter the gastrointestinal tract from three sources: swallowed air, or gases formed in the gut as a result of bacterial action, or gases that diffuse from the blood into the GIT. Most gases in the stomach are mixtures of nitrogen and oxygen derived from swallowed air. In the typical person, these gases are expelled by belching or burping. Only small amounts of gas normally occur in the small intestine, and much of this gas is air that passes from the stomach into the intestinal tract. In the large intestine, bacterial action generates most of the gases, including especially carbon dioxide, methane, and hydrogen. When methane and hydrogen become suitably mixed with oxygen, an actual explosive mixture is sometimes formed. Use of the electric cautery during sigmoidoscopy has been known to cause a mild explosion. Certain foods are known to cause greater expulsion of flatus through the anus than others: beans, cabbage, onion, cauliflower, corn, and other certain irritant foods such as vinegar. Some of these foods, serve as a suitable medium for gas-forming bacteria, especially unabsorbed fermentable types of carbohydrates. For instance, beans contain an indigestible carbohydrate that passes into the colon and becomes a superior food for the colonic bacteria. But in other instances, excess expulsion of gas results from irritation of the large intestine, which promotes rapid peristaltic expulsion of gases through the anus before they can be absorbed. The amount of gases entering or forming in the large intestine each day averages 7 to 10 liters, whereas the average amount expelled through the anus is only about 0.6 liters. The remainder is normally absorbed into the blood through the intestinal mucosa and expelled through the lungs.